So I am going to change tracks a little bit here because my goal is to have you think about mechanisms by which vasculitis might occur, because if you have something of an understanding of mechanisms, you'll be able to think along with us as investigators in the adventures that we're going on to try to recognize the cause of these diseases and the mechanisms that drive these diseases. And once you understand cause and mechanisms, now you're getting very close to better therapies and potentially even cures. So let's not leave anybody behind and start very simple here. So this is a blood vessel. It looks like a hose. It's a hose that's cut lengthwise down the middle. And in that hose is a channel through which, if it was your garden hose, it would be water. But if it's a blood vessel, we see red cells and white cells. And in health, this is your highway system to deliver the white blood cells where they need to go to fight battles to protect you. It's your highway system to deliver oxygen and nutrients and to take away waste from the tissues that they serve. So when we think about this blood vessel and what happens to it in vasculitis, we're talking about inflammation within the wall of the blood vessels. But that's a gross oversimplification, because in many different forms of vasculitis, the inflammation is just not within blood vessels. It also goes outside of the blood vessels into tissues where damage is done independent of the blood vessels. So just to reinforce the notion of vasculitis, I've just changed this picture here to show white blood cells going into the wall of the vessels. And if you will, you might consider that to be something of a little fire within the wall of the blood vessels, a fire that will create inflammatory damage and change the structure of that blood vessel so that it's either going to respond and try and heal and get narrower, or it's going to get weaker and become wider and form what we would call an aneurysm. So what you and I want to know in thinking about this process as autoimmune, what we mean by autoimmune is that your immune functioning cells, which are your white blood cells in the circulation, their job is to protect you, not to attack you, not to attack your own tissues. When that happens, we call that autoimmunity. Your immune function is getting screwed up, and instead of doing its sole role in protection, it actually becomes rogue and stages an attack. And so what you want to know, and what you should hopefully be interested in, is why autoimmunity exists. Not just autoimmunity in regards to vasculitis, because we borrow and feed and learn from people who study autoimmunity in every guise. So if somebody is making discoveries about autoimmunity in terms of thyroid disease or multiple sclerosis or yet other autoimmune diseases, we want to learn from that, because some of the principles from that may be applied to vasculitis and open a window of understanding that we didn't have before. So every conquest, every new understanding in regards to autoimmunity is a gain for us, even if it has nothing to do with blood vessels. So some of us get autoimmune diseases and others don't. And you might ask, well, why is that? And some of it has to do with genetic vulnerability. We're not all put together the same. Some of us jump 3 inches off the ground, and some have a vertical leap of 3 feet. Some of us are more prone to getting ill now and then, and some of us seem to never catch a cold. Well, that's part of our genetic vulnerability. We are imperfect. As much as your parents perhaps told you otherwise, it's not true. We are imperfect. We are a work in progress. We have an immune system that doesn't always work properly. It can make mistakes, and it does. And also, beyond that imperfection, is there are things within the environment that can trick our immune system into working against us. And I'll show you some examples of that in cartoon fashion a little later. And then I want to introduce you to the concept that these white blood cells may not just lose their ability to tolerate you and who you are and lose their tolerance. They actually may be performing normally, but the tissue that is being attacked may have been changed, so the tissue no longer looks like you. It looks like a foreign protein, and so the attack is launched properly, but the tissue is changed. So let's consider that just a little more. Our immune cells are imperfect, can make mistakes. So how is it that these immune cells are educated into what is you and should not be attacked and what is not you? Well, from the time that you are an embryo, your immune cells are being educated in a gland deep to your neck that is called the thymus gland. And during embryonic development, white blood cells traffic through that gland, and it's in that gland that those white blood cells are introduced to everything that is you, all the proteins that are you. And so in that education, they're instructed to tolerate you. And we call those proteins self-proteins. You tolerate your own self-proteins. You love your own self-proteins. You'll never do anything to hurt your own self-proteins in health. And you, in turn, will destroy in health all that is not you, all that is non-self. And so you get the idea? Non-self doesn't look quite like me, invading my body, I go after it. So if you're destroying non-self, what might that be? Well, it might be toxins, bacteria, viruses, dead cells, mutated cells that now no longer look like you, may present a risk to you. Certainly you can recognize these infectious agents would do that. And so when we turn on ourselves, we talk about that in terms of loss of tolerance. We've lost our ability to tolerate ourselves, our own proteins. And when that happens, in the few autoimmune diseases where this has been carefully studied, we know that there are these rogue white blood cells. They actually look like this under the microscope. Some are uglier, some don't look quite as bad. And when you consider these rogue white blood cells within the population of all of your white blood cells, they often make up only like 2 to 3% of the entire group. So immunologically, those of you who might suffer from vasculitis actually look pretty good. You all look marvelous today. It's a Billy Crystal term. You look marvelous. And so that's because maybe only 2 to 3% of your white blood cells are rogue. The rest are doing their job. So anybody who's ever been a teacher knows what it's like to have a rogue student in the class, right? It can make the whole class look bad, but actually the whole class is pretty healthy. But that 1 or 2 individuals who are rogue can really mess up your life that day. And when we're talking about illness, mess up your life. So a well-behaved white blood cell is on the slide here. This is a real one. Scanning electron microscopy, magnification, I can't tell you how many times, probably over 100,000 times. This yellow cell that sends out parts is engaged in taking in this bacteria. Why? Because that bacteria is not self. You want to get rid of not self. And it's doing this 24/7 your whole life. And most of the time, except for sometimes 2 to 3% of those cells, when you develop an autoimmune disease, are doing this just fine, and you're protected. You're protected from all those things in the environment, the external environment, the internal environment. So that is one part of the formula. You can have some white blood cells go rogue, and we don't know why, and that's part of the future, is research that is ongoing to try and figure out why those 2 or 3% do what they do. And what if you can identify them? What if you can identify them from the crowd? Wouldn't you like, if you were in that classroom and you had one bad player, even though you may rehabilitate them, ideally, you'd like to take them out of the class that day. If you can identify them therapeutically, you want to take them out of the class. And unfortunately, we're not there yet, but that's why we want to get there. We don't want to give the whole class a timeout. We don't want to do a number with prednisone and Cytoxan and all those other drugs on the whole class. We want to just extract the bad players. We can't do that yet. So let's talk a little bit about how immune functioning can also be tricked. So we said the job of your immune system is to identify those bad things that get into your body, bacteria, viruses, or maybe mutated cells. But sometimes these things that come into your body actually look a little like self. They resemble your own proteins, maybe just a little bit. And so if we just let your imagination run, and we say this is self, this little rectangle here, but this bigger rectangle with a little decoration on the outside, that's non-self. And your immune system is usually smart enough to take out non-self almost all the time, 24/7. But you know, that non-self protein, it mimics this one a little bit. So at a molecular level, we might call that molecular mimicry. And maybe the immune system is just having an off day, and it's tricked. And so the immune response to non-self then extends on to the protein that is self. And now you start doing hits to your own self wherever those proteins are, just because this thing that looked like you a little bit mimics your self proteins. So this would be a situation where the immune response that was generated was tricked through molecular mimicry, and we think about that a lot in terms of how these diseases may get started and how they may progress. Another mechanism by which we might get to why for autoimmune diseases. There are tissues in your body that may have been affected by external factors that change that tissue's appearance. So that tissue no longer looks the same, and it looks foreign now. Now, there may be internal forces at play too, like, remember I said, in spite of what your parents told you, you're not perfect, and you are actually, as we sit here, having cells undergoing mutations. So those cells that are undergoing these mutations because they're not getting cell duplication, replication, they're just not getting it right. They're doing it for your whole lifetime. It's hard work to do every duplication of a cell exactly right every single time. So sometimes errors happen. And those errors, when they happen at the genetic level, we call them mutations. And so the best example that we know of mutations that really go wrong is cancer. All cancer cells are the product of mutations. And those cancer cells, when they undergo a mutation, they look differently. So if you follow me through this little cartoon here, we'll say this is a cancer cell, and this is the DNA, the genetic blueprint of your cancer cell, and it's the basis for duplication. It separates, it duplicates, the cells separate. Now you've got two cells where you had one, and it's doing this in every tissue in your body 24/7 for as long as you live. But say a mutation occurs, indicated by that bolt of lightning there, and that mutation is now responsible for producing a mutant protein. And that mutant protein may now be expressed on the surface of the cell. So the mutant protein is red. You can see this here is red. All the other proteins on the surface of the cell are normal proteins. Your immune system is tolerant of those because they're self. I know me. I love me. I'm not going to attack me. But this one's different. This is a mutant protein. So even if I have cancer, I'm going to attack this cell, this cancer cell. But if clinically I have recognizable cancer, it means that my immune response wasn't good enough to actually get rid of the cancer. It failed. It just is not perfect. We're a work in evolution. Now, there are other things that can change the appearance of proteins on the surface of the cell. And those things could be an infectious agent that gets into your body and may get into the cells and take over part of the protein machinery of the cell and express new proteins on the surface. So it doesn't have to be a mutation. It could be radiation effects. It could be other environmental factors, toxins that you acquire that change the protein profile of what exists on the cell. It's not cancer, though. But it's a change in the cell. Now, if it's not cancer, what might your immune system do with this mutated cell? Well, it's supposed to do its job, and most of the time it does its job well. So if that mutation is here within the wall of the blood vessel, then the immune system is going to respond because that protein within the blood vessel looks foreign, and that triggers the immune response to get that protein. And that could also be a cause for vasculitis. And I'll even show you an example where we know that happens. So we're very interested in these white blood cells. We want to know what they're reacting to. What is the protein that is driving the white blood cell response? It's going to be a foreign protein or a new protein. And when we talk about proteins in the context of the immune response, I want to teach you a new word, or for some of you maybe it's not a new word, but when our immune system responds to a protein, we call that protein an antigen. And for purposes of this discussion, we're going to abbreviate that AG. The immune response to a protein to an antigen. And so we want to know what that antigen is. We want to know exactly what the identity of that antigen is if we're going to make progress in understanding the disease and progress in designing new therapies. And we're going to want to know whether or not we generated that immune response because we've lost tolerance. Is it a primary abnormality of the immune response? Or is it a mutation or an otherwise newly produced protein on the cell surface? That's all important in understanding the disease and ultimately in designing therapies to block the process. So there's another layer of complexity to this vasculitis thing. We see vasculitis, as Peter introduced you to, in people of all ages. Sometimes there's a gender preference. Giant cell arteritis, Takayasu's female predominance. Sometimes there isn't a gender preference. But the patterns are very, very different. And now that you know about antigens, when you think about the patterns and what drives the process, you might begin to think that maybe certain areas that represent the patterns of vasculitis are represented in that fashion because the antigens that are abnormal are located in some areas and not other areas. And that sets the stage for the attack in some places and not others. So let me show you an example in a disease that affects only children that we call Kawasaki's disease, a form of vasculitis. It's predominantly Asians that are affected, but also we see a fair number of these kids all over the world. 80% of the children are less than 5. The peak incidence is less than 2. And it's not all vessels. So vasculitis, get away from the idea that this is an equal opportunity category of disease where all vessels are vulnerable. That's not the case. All vessels are not vulnerable in vasculitis. There are patterns. And so we call this a medium-sized and sometimes large vessel vasculitis, but not even all medium-sized vessels are vulnerable. Now, in showing you that description, I'll also show you a child with Kawasaki's who looks very sick, very febrile, has this rash, and has heart disease because the heart and the coronary arteries of the heart are particularly picked out in this disease. And this is an example also of a form of vasculitis that involves inflammation in tissues other than the blood vessels too. And this, sadly, is a post-mortem specimen from a child. These are the lungs on the outside. This is the heart here in the middle. And when vasculitis affects children with Kawasaki's, it produces aneurysms, weak areas in the wall that have been affected by inflammation, aneurysms that have an increased risk of clotting. And when they clot, the blood flow within those aneurysms clots because of turbulent flow. There may be now no further progression of blood flow beyond that clot, and the child has a heart attack, which in this case was a heart attack that killed the child. We don't see this disease in adults. Now, just giving you this description, you already begin to have a feeling for what are the components, the determinants of what it is that is required for a child to develop this disease. Well, genetics are important because Asians are preferentially involved. The environment is probably important because I didn't tell you that there's often clusters of children with these diseases. Often they will be more highly concentrated in certain zip code areas, or in Japan the equivalent of that. And then there's this age-related vulnerability. So your vulnerability to any disease as a child may be greater for certain diseases than as an adult, and then as an adult your vulnerability goes off the charts because you become much more vulnerable to many other things that children never get. Now let's go to the other end of the spectrum and consider giant cell arteritis of the elderly. Average age is 74. You almost never see the disease in people less than 50. And you see it mostly in northern latitudes. The greatest concentration of reported cases of giant cell arteritis are actually in Iceland. And then the Scandinavian countries follow. And then the northern latitudes of Europe and the United States and Canada. You see it less and less as you get closer to the equator. And this is large and medium-sized vessels, but not all large vessels, not all medium-sized vessels, and sometimes smaller vessels. And there's a predilection for, this is the aorta coming out of the heart, the main highway that takes blood flow through the body. And these are the branches that go up to the brain and out to the arms. This is the more favorite sites for inflammation and damage in giant cell arteritis. So again, here we're hearing something about genetics because there are certain populations that are more affected than others, gender, more frequent in women than men, and age setting the stage for preferential vulnerability, changing vulnerabilities throughout life. And again, that word antigen comes up here. And I'm asking the question in our research whether or not there are unique antigens in these areas that are preferentially involved that wind up setting the stage for why targeting occurs. Is there targeting because these antigens are normal and we've lost tolerance, or have the antigens been modified in some way so that we're attacking something that now looks foreign? These are answerable questions, and I think we'll have the answer to some of this actually within the next couple of years. If we get this knowledge, we're in a much better position to plan rational therapies that are target-focused rather than generally immunosuppressive. So as I wind up here and try to set the stage for you getting a better feeling about how these diseases occur, I want to talk to you a little bit about those examples where we know the cause of vasculitis. And in some instances, it's related to viruses, virus infections. And the one that we understand best is hepatitis viruses. Now, again, it's not all blood vessels. There's selectivity of blood vessels and organs involved. So if you have hepatitis and cryoglobulinemia and vasculitis, you particularly are in a situation where the inflammatory cells like to home in to the kidney, to the skin, and to the nerves. And where you don't see the white blood cells go in this disease is to the lungs. So we say this is a small vessel vasculitis, but it's not equal opportunity small vessels because the lungs are not involved, the pancreas is not involved, the brain is generally not involved. So not all small blood vessels are the same. They're very different in organ to organ, and what invites inflammation in one site may not invite inflammation somewhere else. Now, in the case of bacteria, we also know that there are certain bacteria that like the aorta, particularly the starting part of the aorta, and that includes TB and syphilis, and there's a lesson to be learned there too, because we don't see involvement of the aorta from these organisms in other sites, usually. So there is something that is putting out in these organs that are affected, something that is putting out a welcome mat. There's a welcome mat that bacteria or that virus finds particularly inviting. I'm going to come into this house. I'm not going to come into that other house. I'm going to establish a pattern in my disease as I generate it. So is it possible that there are yet other forms of vasculitis that are due to infections? Absolutely possible. And these are works in progress. And then you ask the question, if I find evidence of an infection, is the infection ongoing? Is the virus, perhaps the hepatitis virus, we know it is, the hepatitis virus is remaining active and replicating and growing, and its numbers are increasing in those patients who have cryoglobulinemia and hepatitis. But there's another possibility, and that is that the bug comes in, or the radiation exposure, or the toxin, whatever it is, comes in and changes self. It binds to self-protein, the protein you have learned to love and you don't react to. It binds to it. It alters it. It makes it different. And now you trigger an immune response to self, and through what? Molecular mimicry, you then attack your own self proteins because you've generated this response to altered self. Now, the viruses that we're talking about here are not just hepatitis, because hepatitis, HIV, EBV, which is Epstein-Barr virus of mononucleosis, CMV, cytomegalovirus, which is sort of like EBV, parvo B19 virus, all of these have been implicated as causes of vasculitis. But actually, they do it very, very, very rarely. And so what sets the stage? Another area of research that you should be looking to in the future. It's genetically who you are, immunologically who you are. What are your relative vulnerabilities that allow this virus to then start that pathway down that road that we call vasculitis? Because when we look at these viruses, it's only about 1% of the people who might get these viruses who ultimately get vasculitis. So again, genetic vulnerability, immunologic vulnerability, we need to define those vulnerabilities better because we can change vulnerabilities. Look at EBV. This is fascinating. This is absolutely fascinating. So the same thing with EBV, Epstein-Barr virus, the mononucleosis virus. What does it do given different immunologic vulnerabilities? How many diseases could one infectious agent cause? Well, for most of us, show of hands, how many people have never had well, how many people have had mononucleosis, you know, the swollen lymph nodes, the fever, all of that? So small number of people here. How many people think that everybody in this room has been infected by mononucleosis virus, the EBV virus? We've all been infected by it, but only some of us develop mononucleosis. Most of us have had a silent infection. But if we drew your bloods and looked for antibodies, evidence for having prior mononucleosis, you wouldn't have necessarily had mononucleosis, but you would have had evidence of an infection with EBV. So the next most common thing we see from EBV is mononucleosis. And the next most common thing we see is chronic infection that doesn't go away because some people are not able to clear the virus. And then we see lymphomas. We see types of cancers related to EBV. If you lived in West Africa and you were African American or African in that case, EBV would be driving a lymphoma called Burkitt's lymphoma. And then there are yet other disease, what we call phenotypes, other types of diseases that are driven by your genetic profile and your immunologic vulnerability. So the bottom line here, important for you to remember with infectious diseases, it's not what you get, it's what you do with what you get that determines whether you get sick or not and what your pattern of disease is going to be. Now, let me end with something that I'd like to give tribute to our young generation of investigators within the vasculitis community. And this is a tribute to Curry Koenig, who is here and will be speaking later today, and Ivana DiDomenico, who are leading a study on giant cell arteritis, trying to establish proof that this is an infectious disease. So they did temporal artery biopsies in GCA, giant cell arteritis, in patients who had that disease in normal controls. They probed those biopsies for proof of bacteria being present, and they in fact found something. They found a bacteria called Burkholderia. They did not find it in the controls. And they recognized that, that this Burkholderia, that they're now calling Burkholderia GCA, is producing a unique protein, we'll call it LPS, a protein, an antigen, that there's an immunologic response to. And you could find it in the blood of patients with GCA but not controls. They've done that already. They've used special studies to stain the bacteria within the temporal artery biopsy that is done for diagnostic purposes in making the diagnosis. And here you can see some glistening areas in orange. This is just a lower power. This is magnified. That is proof that the Burkholderia is in the blood vessel wall. And they do not find it in the people who do not have GCA. This is what we call seminal work. It's extraordinary work. It's terribly important work. It needs to be confirmed. And there is, because this is a bacteria, ongoing antibiotic trials. Vasculitis, imagine, cured with antibiotics, a disease for which we've only treated effectively with steroids. And there are other opportunities from work like this. Once you prove that this is in fact the case, you might want to say, why does Burkholderia go to certain blood vessels and not others? What does the welcome mat look like in those blood vessels? If we don't have an effective antibiotic, can we do something to take that welcome mat away and make those blood vessels less vulnerable? Lots of opportunities. Why some vessels and not others? Can you apply these same types of techniques to look at other causes of vasculitis? This is a good example of how putting your foot in the door for one opens the door for others. This is why we're the Vasculitis Foundation and no longer just the WGA. This is a great example of that. And so I'm going to make a pitch here at the end to share with you a problem that we have. Our greatest pride is when we train young people who come along and contribute, as Peter has, although he's no longer young, rapidly aging as the chief at Penn. But that's why we train, yes. Okay. But So Curry is one of our recent graduates from our fellowship program. And so what I think you need to know is how many people like Curry do we train? How many people like Peter Grayson do we train every year in the United States to do this kind of work? 3 to 5 throughout the United States. That's a disaster. There's not enough people out there to take care of you and to make these discoveries. This is a disaster. And, but it's far better than where we used to be. But it's not enough. We have to train more people like this. And they need to be trained in classical rheumatology and vasculitis, but we need people who understand other areas. We need people from infectious disease and immunology and veterinary medicine, on, not just the traditionally trained people. And so the challenge is, how do we get the money to train these people? That's a thought I'll leave you with, and I hope that what I've done is to give you the infrastructure, the foundation, to think about how we think about these diseases, and as our understanding of these diseases improves, how it gives us enormous leverage to develop new therapies. So thank you very much for listening.